On the outside, I would like to thank the All India Ophthalmic Scientific Committee for accommodating a very abstract topic of surgical adaptability in macular pathologies in a medical retina session. So thank you all for taking and considering my topic. So, these are basically thoughts of various adaptability which you do while you're doing surgically handling any macular pathologies. And as a retina surgeon, macular pathology is one of the challenges which we encounter and that really thrill us. The slides are not moving. Okay. So the adaptability is the quality of being able to adjust to new conditions. So this is the system that we just had in our OT, and this is the OS4 system, and in this we come with the 3 LED illumination system. So you can basically play with the different wavelengths, and as you can see, it was just a blue wavelength which I had maximized, and once I switched to the yellow wavelength, the depth perception as well as the visibility of the ILM is great. And this is very, very handy when you are doing any surgery in which there is a myopic change underneath it. And this helps you to adapt and grasp the ILM, which is you have to going to handle it. So this gives me a very enhanced adaptability, enhanced visibility of the ILM. Now at this point of time, there is a macular hole, and here you notice that as I'm trying to grasp, the whole of the retina is moving. And this point, I have to adapt myself that I go and restain it again, rather than just continuing with it. And once I restain, you can see there is a very nice remnant or island of ILM which you can see. And this is going attack is basically what was pulling the whole of retina. So at that point of time, I was thinking that I'm even grasping the retina. And there is a red dot which sees that there is some amount of trauma that might have caused during my previous maneuvers, which might be the exact lying middle in the papillomacular. This patient I closed it under gas, and this patient did very well. Now, ILM is one of the tools that we use to address different macular pathologies, and we use it in different forms. You can adapt, you can stuff it, you can put it over any defect, but then there are situations in which you don't have the ILM, so we'll have to learn and adapt ourselves to lost flaps or where ILM is not there. So this is another case. So this was a patient which was operated for macular hole RD, and when I was doing SOR, I could see that there is a persistent macular hole still. So I restained it, and then what I planned was an ILM translocation. So in this case, I took an ILM from other area and I translocated it, and fortunately this hole got closed. Now, you not always be that in cases which we will have or amenable to ILM. So this is a patient which was operated in Maharashtra and came to Bihar after 2 years, and for that time it was carrying that RD. So this is an atrophic retina, and you can see there is a streak of break that has happened while I was sweeping the whole of posterior pole through my diamond duster scraper. So I used this break as one of the a template where I would take the retinal autograft, and in this case I did almost 270-degree retinectomy also, and I created it through a curved seizures, and then I moved this for using as a retinal autograft. Now the process here was not just the functional outcome, but I know that this is a one-eyed patient, and if this hole, unlike other holes, it might be do well, but in this hole, if I leave it well, then there would be certainly a retinal detachment which would be there. So this here was more of an anatomical outcome that I was looking for, and this is what why I do the retinal autograft in this case. Now, another piece is that in which you can do an optic disc pit maculopathy. Here we have to, if you look at the fovea itself, there is a large hood, if I would pseudo-OCT, and if I would just do any ILM peeling over it, then it would just blow out. So I do a temporal graft, and then obviously the literature, it doesn't say that you have to do an scleral patch autograft, but in my case, if I have to do, I would not just restrict myself to ILM, I am quite comfortable, then I would also, I am also regularly doing a scleral patch autograft. And these are the result of few of the cases that I have done. Now, we all encounter long eyes, the patients which have MTMs, and then they pose a different. And there is a wonderful classification that has been given by Dr. Parolini and group, in which they have classified the tangential as well as the vertical forces and where it is balancing. And once you feel that the vertical forces are outweighing the tangential forces, there you have to go and negate that vertical forces. And here comes the role of macular buckling. And this is a case which I did around 7 years back. This was a modern Devon T implant which we did. And this is the result post-operatively, in which we can, and this patient has not been treated for, this was just a primary modern Devon T implant. Although there is a shallow amount of cuff of SRF which was still present, but I think it was a pretty good outcome for it. And this is my mentor, Dr. Ihas. I wanted to show his video because when you are learning to adapt something, this is one of the, if you have various surgical macular pathologies, this is one of the great adaptations that I have learned. It's obviously very scary that you put a catheter just under the suprachoroidal space and you transfer the whole suprachoroidal space and then you inject a visco filler. And these are basically the skin fillers that you use, and you cause under the suprachoroidal space, you cause a sort of detachment, and that acts like a sort of a macular buckle. But then it is a temporary. And when I asked him that these spaces, they have their own memory, and they last for a really long time, although the fillers are, technically they should get washed at 3 to 6 months, but they have their own memories, and then you inject it. So this is one of the things that he adapted for his own convenience, and we can learn from it. But whatever you do, there will always be a unique problem, and this is a case in which they have a radial vertical, it's a horizontal slit, and the issue was that these slit had an outward folding of the retina, and I tried a lot of things to unfold it. One of the last resort was to do all around it and try to fill it. And finally, when I found it insufficient, I did a retinal autograft also, a large retinal autograft. I don't think this is a very great outcome, but then this is how you adapt yourself. Thank you. Thank you for my.
Great.
Yeah, wonderful, Abhishek. This is what was expected from you, that multiple videos and how you adapted to various modifications.
Thank you, sir.
The change of filter was very, very nice, where you shifted the filter and the illumination, and it became very nice visualization of ILM.
Even sir, Alcon is also coming with their different wavelengths. I think it's just in the process they are going to come with it. Yes.
And all the subsequent videos, I think there was a lesson to be learned. Do you have any comment to make? I am not a very strong proponent because you have experience. You said you did a couple of years back.
Yeah, sir. So, but I just want to take a feedback from you because you are a more avid practitioner and you have a long hand. I somehow feel that unlike the Western data, we don't get that much of MTMs in our practice. I don't know why.
We do get. These patients keep roaming
But
around.
the volume to build a consensus. That is what I'm saying, sir.
So in a third case where you shifted to a retinal autograft,
yes, sir.
Why didn't you try ILM graft?
So in that case, that was an atrophic retina, sir. I stained it, but the stains were not picking it up that well. And when I tried to pinch it to some sort of flap, it was just injuring the retina. Either the ILM had got fused or something, or the previous surgeon had already done it. It was an atrophic retina, sir. That is why.
Because there is criteria that this dimension of the hole where you decide ILM versus retinal autograft.
Sir, my criteria is fixed. If I have to do, what is the indication for doing a retinal autograft? I would first give a chance to all the conventional methods. In this case, I felt that I'm not able to, and if I leave that hole open, this patient is one-eyed, this might go. And sir, if I can share my thought process, sir, this patient after 1 month did a slight, there was slight SRF present at the posterior pole. I went again, and there was an anatomical integrity of the graft with the host tissue. That is what I could document on the video, sir.
No, Santosh, there are people I know of who without doing an ILM autograft, they straight away do retinal graft.
But in this case, that was something I felt that it was required, sir.
Anyways, thanks a lot, Abhishek, for this wonderful